Okay, so presentations open for questions, comments. Doug, I'll start off. In your c-KIT mast cell tumors, do you get overexpression in the non-IDT mutated patients?
So I don't think that we really have a good answer to that. So we can say that in the study that I mentioned earlier, where we're looking at the acquired mutations, one of the things that happens in addition to mutation is actually some overexpression to the tune of about a half log. So it's probably not enough to be responsible for the profound resistance that we observe, but it does appear to be another compensatory mechanism. Cheryl, can you answer the question about whether the wild types tend to overexpress KIT versus the mutants?
Sorry, we haven't looked at the genetic level, at the gene level, to see if they've got copy number increases. We can certainly say that there's a subset of mast cell tumors that are wild type that do have very high expression of KIT. That may or may not correlate with phosphorylation, and that's based on flow.
The other thing that appears to be present is a certain percentage of canine mast cell tumors that may have autocrine stimulation through the production of stem cell factor.
So I'll go over here. I thought it was a fascinating group of talks and truly interesting. And I'm actually going to pick on the last talk that Doug did to ask sort of a more general question, which is, you know, the BTK study was done at the time when the most widely known effect was of the drug was to inhibit Bruton's tyrosine kinase. And over the last couple of years, we've learned that that drug also has a really interesting effect to inhibit ITK and enhance T cell activation. So, you know, using maybe your study as a starting point, but addressing this really to the panel and the whole community, do you know how good we are at retaining the material from these studies to be able to go back later and ask post hoc questions? For example, were we seeing an amplification of the immune response in those patients when we gave them the BTK inhibitor, which might have actually correlated as well or better with clinical response and inhibiting BTK in the B cells?
Yeah, that's an outstanding question, Jaime. And I think one of the things that we've learned over the years is, to the extent possible, bank everything as often as you possibly can. So whatever it is that you don't collect, that's the thing that you're going to end up needing. So again, to the extent possible and dictated by the guidelines of the sponsor, we really do try and bank serum, bank urine, to bank PBNCs when possible. But you know, the unfortunate thing is we can't anticipate sort of all of the possible things that we could possibly need. But in general, when I'm having discussions with sponsors, what I really do try to encourage them is, please let us collect up as much as we can, so that exactly that can happen, so that these samples will be available for exploratory post hoc analyses down the line. So all you can do is point out those kinds of examples and say, look, this is why we really want to do that. And hopefully they understand the potential value. But yeah, a very important point to make.
So one of the major, Michael Casten-Duke, one of the major goals of this conference is to identify the gaps in which we can use trials in either patient population to inform the other. So since we're in the era of targeted therapies, and clearly the canine models have some of the same mutations that we have in the human settings, but clearly some of those times it's not the driver mutation, as we heard this morning.
Yep.
What I'm wondering is whether we can still get information in those settings. For example, with the BRAF mutation in bladder cancer that we heard about this morning, using a BRAF inhibitor and using a biomarker to say, yes, we're hitting it and this is the appropriate pharmacodynamics or kinetics that we need to use, and we can hit it even if it's not the therapeutic panacea for that particular tumor. Is that something that's useful in the canine model to apply to the human setting where, for example, in melanoma, BRAF will be very relevant?
I think it certainly could be. And again, the autophagy study that Dan brought up, I think, is a great example of that, where I don't think any of us really expected to see single-agent anti-tumor activity with hydroxychloroquine. The goal of the study was to sort of develop and validate a toolbox of assays that would be usable either for future autophagy inhibitors or to demonstrate that sufficient target modulation was occurring to inform later combinatorial studies. I think another example that's worth bringing up might be the monoclonal antibody story. So we're potentially, not always, but potentially hamstrung by the development of neutralizing antibodies that may limit our ability to do multiple sequential effusions with a targeted therapeutic that's a protein-derived. However, again, answering short-term questions about binding, delivery, PK, again, potentially imaging-based endpoints. Are you hitting your target or not? If you're looking at short-term questions, I think can be very, very valuable, specifically through establishment of that PK/PD relationship. Anything to add, Dan?
Yeah, I mean, I think target modulation is one thing, but I would argue that a lot of the driving mutations we're seeing in human cancers, and vemurafenib and melanoma in people is a good example. Those are not very robust responses. I mean, they happen quickly, but then they wane. The molecular workarounds that we're learning about, how cells are getting around those, I think may be very relevant in the dog model, where you need to look at how you modulate one pathway in the context of what's coming next and how you inhibit that, because that's really going to be a drug combination issue, and it's going to be a toxicity issue when you start loading up on multiple TKIs, because you have to maintain inhibition of one pathway when you get these workarounds, because that other pathway is still mutated. So I would argue that the driver mutations may not be as important as the fact that they're there and they can drive proliferation or signaling mechanisms. So it may be more like the human condition when we have these drugs on board and they're driving the cells to adapt to that.
Wendy Shelton, Virtual Beast. Doug and Dan, and you've all spoken very clearly about your successes and how this has worked for you. And Doug, you've spoken a little bit about some of your frustration, things that maybe won't work. If you could just project forward and think in more general terms, sort of at a higher level, what your frustrations are from your relationship with industry or your relationship with the gaps that you have. What do you need?
Sure. So, I mean, I think there's really the major issue, and this has been brought up by others, is really a lack of very comprehensive characterization at the molecular level of the mutations that are present in canine cancer. So again, when we're talking to sponsors and we're talking about potentially evaluating their targeted agents, they say, well, what tumor types have BRAF mutations? What tumor types have, ALK fusion genes? And to a large extent, we're not able to necessarily answer that question. We have the tools to go in and ask that question, in a targeted way for a particular sponsor if they're interested. But I think, again, what I would love to see is a more thorough interrogation of the spectrum of alterations that are present in a large cohort of canine cancers, so that we'd be able to look someone in the face and really understand where certain drugs may be most efficacious. So we know what tumor type to target, or what mutation to go after. Say we know that some tumors have this, irrespective of histotype. We know that we can design one little set of sequencing primers to amp it up, and know on a yes/no basis whether this is an animal that would be worth enrolling into a study. So anything to add, Tim or Dan?
Yeah, just toolbox and access. I mean, can you get the drug? Can you give it in enough to do what you want to do? I mean, we have lots of stories of how we've come across things to do studies. In the past, sometimes the drugs fell into our lap in ways that were probably not legal. But, but I mean, it's access and, yeah, no, it's well.
Yeah, I would resonate that is really, number one, we don't know thoroughly if the molecular target is uniformly existent in some of the tumors that we're interested in studying, but also the drug, will pharma actually provide us log orders more than what we would typically request for a mirroring preclinical study. So we're talking about, as Doug said, thousands of times more quantity. And I think my perception from a lot of pharma is that that's a lot to ask for, especially if we're not able to prove to them that the target necessarily exists. And so I think that's a big hurdle right now.
Thank you.
Mark Dewhurst, Duke University. Thanks, Doug, for bringing up the importance of imaging. I just wanted to just make a plea. I think we have an opportunity with these models to ask the following question, and that is, does the drug get to the target tissue at all? And imaging can be used for that, and particularly if you had the ability of combining functional imaging, say DCMRI with biopsy, you could really start to look at that and say, are we hitting the target or not? Because I think that's inadequate concentration, and it gets at the issue of tissue heterogeneity and tumor heterogeneity as well.
John Hare, University of Virginia. So this is kind of a granular question, but does PAC1 work if it's conjugated with a linker arm to an antibody and released in the endosomal lysosomal system?
So we've looked at a couple things. We've looked at the fabrication of a fluorescently labeled PAC1, and that has allowed us to look at some in vitro studies. It dramatically changes the molecular size of that molecule, so it does change the ability for it to fastly cross membranes. We have looked at the feasibility of encapsulating into a targeting nanoparticle. I don't know, how would it affect the endosomal? We're not even certain. I think it just it's very lipophilic, so I think it just passively passes through the membrane. I don't believe that it's any type of endosomal trafficking per se, but I think the molecular size and the polarity has influenced its ability to get into cells in vitro at least.
So I want to try to be hold this to a little bit more stringency, because all your presentations were great, but I would say at this point in time, most pharma companies have a pretty good idea, one, of a credential target, that there is a driver mutation. And they have a pretty good idea that a drug they're ready to move forward is pretty good at blocking the target, at least in every way, prior to getting into a human. And in fact, I would say that most studies now, pharma and other, even the NCI is pretty strongly pushing, trying to do pharmacodynamic measurements, that is, on-study biopsies in patients looking for hitting the target in the tumor in humans. And so I guess I'm pushing for what are the questions, and Carl, maybe you can answer this as much as anybody. What are the questions that would help, and I think, Doug, you mentioned, yeah, it's nice to see a real dog tumor respond, but I'm not sure that's really what we need to see at this point. And one specific question, Dan, is I thought that data on the lack of correlation between plasma or neutrophil or PBMC concentrations and what you got in the tumor was pretty interesting. But again, I would ask Carl, how important would that be, given the era where we're really asking to biopsy tumors? Is that a big step forward, or what's the real sweet spot here? I'm probing because I don't know.
Any of the panel want to answer before I speak? I can show you 10 examples of that difference between the surrogate tissue and the tumor. So we do all of our PD markers in tumor-based, and that's the only way we accept a drug going forward.
That's what I'm saying. That's not surprising.
Not surprising at all. The value of doing surrogate tissues, when the correlation is occurring, then you can get longitudinal temporal studies, so you can understand the duration of inhibition, which you cannot do by multiple biopsies. And I was going to actually ask a similar question about sort of, you talk about getting serial biopsies. Well, I do that routinely in our phase 1 trials in patients.
In humans, right?
Exactly. Yeah. And what we heard about was lymphomas and melanomas. Those are very easily accessible tissues in the human. So do you get pancreatic biopsies? I mean, are there some of the more difficult ones that, we cannot get access to in humans? That would be one question. And then before I shut up, to your point, where do I see the value? I mean, there are some tumor types in animals, in companion dogs, that are difficult to study in humans, osteosarcomas and some of the sarcomas. We really don't have good therapies for those, and so that's where I'd put my effort if I were in this business.
Well, I would have said that too, but I study sarcomas.
I knew you would.
But I guess my one question would be, when these drugs are in broad usage, a lot of their use is going to be in the adjuvant setting. You're in no way going to be able to sample at that point to look at biomarkers of response if you have early markers of response that you want, because patients may go on something else. So there's a difference between what you can sample phase 1 and experimentally in a human and what you're actually going to be able to do later.
So you validate my point about being careful about biomarkers. You talk about biomarkers of response, absolutely. And actually, I want to address Lee's question about sort of how do we understand acquired resistance mechanism. So there's a revolution in using circulating tumor DNA. So that's built into all of our trials. And so I can show you a patient, I can tell you a patient is going to respond 2 months before Pete Choike can with his CT scans. Okay, and I can take that cDNA and I can sequence it. I can do whole genome sequencing and I can do targeted sequencing with 300 genes, and I can tell you what the resistance mechanism is. So I talked about our 3rd generation EGFR inhibitor. Before the phase 3 study was published, we had a resistance mechanism. We had a drug discovery process ongoing for the next generation of therapy. So things are moving very quickly in the human setting, using mostly ctDNA as a response marker.
But that's not much different than what they did with Gleevec 15 years ago, right? I mean, they had dasatinib was around very quickly afterwards because they knew what mutations were going to drive.
No, exactly. And we've been trying for 15 years to replicate the Gleevec story. And so, we have done that both with next generation, BCR-ABL concept, and now we can do it also with other drugs as well.
So Jerry Post with Animal Cancer Foundation. Great presentation. One of the things I'd like to ask is timing of drug delivery. So in the disease, so can the models that we're proposing, what do they offer in terms of giving the drug earlier or at a more biologically relevant time frame in relation to the disease, whereas in human clinical trials, you have to wait until they failed standard of care. Could you speak to when we are able to give novel therapies in this model?
So again, just chime in a little bit to that. So I think that, again, that goes back to what many people have alluded to in today with regards to what is the gold standard for the management of different types of tumor histologies and pet dogs. And I think that there are certain therapies that we view as first-line therapies, but there is a lot more gray. There's a lot more gray zone with regards to, well, what is the best therapy for a dog versus a much more standardized therapy for people. And I think for that reason, it does afford an opportunity to introduce to the concept of a novel therapy earlier on in the course of disease. And that, to my mind, it would be an advantage that you could actually introduce an investigational therapeutic earlier in the course of disease to evaluate its activity, and what we may not be able to do in a traditional human clinical trial in which you may have multiple failed therapies and heavily pretreated patients before you can investigate that therapy.
So just maybe a follow-up to Lee's question and a question for you, Carl. So given that you're now able to easily do pre and post biopsy studies in human patients, do you see an opportunity to fine-tune those sampling time points and collection processes by asking those questions first in dogs? And the reason I ask is that the simple question of let's take a sample and look for a phosphoprotein. We've shown how difficult that is to take from the dog clinic into the laboratory. So it seems to me that even if you are doing it in human patients, there's value in asking those questions in dogs so that you do it properly in human patients.
I agree. I think there is, again, based upon our sampling on sort of our preclinical models, which usually mice and rats, and unfortunately, we don't know that we picked the right time because we only get one shot on goal. So we do, we try to do studies where we get at the Cmax to see if we're hitting the target, and we can sort of show what the based on PK when the Cmax is. So we want to see what the inhibition of a target is at the Cmax, and then we do things later. Sometimes we do things later at Cmin. Sometimes we do things later at like 2 or 3 weeks to look for adaptive responses, not acquired responses, but actually changes in the signaling transduction pathway. So again, it's difficult, but we can do those things. And if we could do it better in the dog, that would add value.
One quick comment. Dan Tumas at Gilead. So I think everybody's talking about similar things, and that is monotherapies. And we've done a lot of monotherapies in humans. We've done a lot of monotherapies in dogs. At the end of the day, we all know that combination therapy and hitting multiple pathways is key. And it seems like that's a very difficult thing to do in human beings. Certainly with the number of possibilities, one can rationally pick good combinations. What are you guys' thoughts on evaluating specific rational combinations in dogs? And there, the application of the PD and pathways seems to me would be the most important thing that could help clinical development.
I agree with that completely, and I think one limitation you have in the human side is you have standard of care that you run into, which doesn't exist really on the veterinary side. And you may be dealing with a cytotoxic or a cytotoxic combination that may be contraindicated or something you don't want to give. And so I think you do have opportunities. The toolbox is smaller with the dogs because we don't really have a taxane. We have some other issues. But yeah, I think that's absolutely true.
And I'd add that I think there are ethical ways to do very careful paired dose escalation studies with multiple novel agents simultaneously, which is something that it would be much more challenging to do in humans, where generally single agent therapy is performed first with a novel agent. So it's challenging, and it has to be done very carefully, but I do think that there are strategies that are appropriate for doing those kinds of double novel agent studies in dogs.
Can I ask you one question about a topic we haven't really heard about today, about the host tumor microenvironment? So this is something that's been very challenging in human studies, and increasingly an area of important interest, I think, to drug discovery and pharmaceutical development. Do you have any particular insight or ways we might consider interrogating that in the context of dog animal models? That would be no.
Excellent. Okay. Last question.
It was mentioned before that the targets that are present in canine tumors are not really well cataloged as they are in some of the human tumors. Just thinking outside the box, and if you had a way to get that done, how would it happen? How can we make that happen, which would help us to focus our research efforts even more?
So, that's a big challenge because, that kind of undertaking is not hypothesis-based research. So it does become very challenging from a granting agency perspective to find funding for that kind of undertaking. Honestly, I think that one of the most intriguing ways to move forward with that would be through a pharma partnership, where, again, there are plenty of big pharma companies out there that have the bandwidth to undertake these kinds of efforts. And again, with the sort of appropriate sharing of data, I think that could be a way forward of mutual benefit. But again, that's something that's really a tough nut to crack because of the granting landscape, I think. I'd be curious is Jeff still here? I'd be curious if he had any ideas about how to do this on a large scale.
I mean, I think there's the genomics question, but then there's also the phenotypic drug screen question, because I think melanoma came out because they don't have the BRAF mutations, but we looked and they had, and it had been shown before, they had MAP kinase activated. They're sensitive to MEK inhibitors. So it may not be just the target. V600E might not dictate that you block that pathway. It might be different. So we don't need just only genomic screens. We need to look at some compound screens, I think, to really get an idea of what's going on in these types of pathway-based therapies.
All right. Well, thank you all, and we'll move on to the next session.